Okay. The two meth heads that got a hold of flare guns and decided to have a duel. Yes. You're supposed to take more than 2 steps before you turn around and shoot. Otherwise, you give people simultaneous subdural hemorrhages. Pretty sweet. Again, not stupid questions, or stupid people, just very stupid questions, whatever. I'm confusing myself right now. Don't worry, I'll go get a CT scan, I have a little TIA. No big deal. All right, we'll get into coma if I have no questions. Sound is good back there. How about the pace for the first time? Most people go faster, faster, and then the eval, I get like a bunch of people like, should go slower. And I have to say faster and all you out, so whatever. Coma. Of course, we're going to check on learning, and I'll reiterate some of the finer points here and the things that I think are important. So, reduce alertness and responsiveness with this. So, these people cannot be aroused no matter how hard we try. So, the Glasgow coma scale, and I told you that was definitely on my PANRE, which means it's something you need to know, it's something you need to get good at. It's a great gauge to give somebody that hasn't seen a patient, and they can rescale them later. You have that initial Glasgow coma scale. Is that person improving or decreasing? Something I would always give if I had somebody being medevaced, I would call the forward surgical team and say Glasgow coma scale is block. So that they know when they come in, like, he was at an 8, oh crap, he's at a 6 right now, we should probably throw a 2. So it should give an idea. Scoring system for that. Very simple. It only addresses verbal, motor, eye functions, but realize there's some limitations there because we're not addressing any other higher cognitive functions. I'm not talking about sensory, not really doing a whole bunch of motor, even though we say we are, but we're not specifying on where those deficiencies are. And here's the guy I want you to pay attention to. I'm not worried about children at all, but I am definitely going to test you in the adult arena. And when you say flexion and extension, for motor, we need to know exactly what that means. That's like flexion and extension, sorry. So decorticate versus deceribate. What does that mean? I'd rather somebody be decorticate all day long. Deceribate, look at that, pretty bad. 10% in deceribate that survive. 1 in 10 versus almost 4 in 10. Huge difference to be like, are they in decorticate or deceribate? More of a flip of the coin versus, yeah, flipping 10 dimes and only one of them counts. So be aware of that, which is worse. So your deceribate is much, much worse. So how does this work out if this person has a tube in their throat? Because we can't assess verbal. We can't assess verbal because there's a tube down their throat. So what do we just do that? We just assign at one point, but we put a T at the end of that. T for tourniquet. So you could say T for time, but because that's how important it is to do that. But right there, so 11T is the highest you can get if you're intubated. The lowest you can get is a 3. That is like 0 responsiveness. So I think it's interesting because when coma is not aroused at all, but you can still get eye opening and whatnot. It's very interesting. So 13 to 15 mild, 9 to 12 moderate, then we get 8 or equal. That is going to be rapid sequence intubation in emergency department terms. Not just an intubation, rapid sequence intubation. That means on a whim, we are giving sedative, paralytic, and then intubating our patient. Go ahead.
Is the T count for 1? Because our slides say 10.
Did you guys download the newest slides?
The ones from yesterday?
Yeah, it should have been updated. So with this 3 teeth, there's nothing from a 2 teeth. That was that's old school, like a long time ago. So the lowest you can give is a 3 teeth. You still have to assign 1 point, even though you can't assess them. It doesn't get 0 points. There's no such thing as a 0. If we go back to this, there's no 0 on the scale. So, sorry if that's an old slide, but everything should be updated with 2026. Ensure that you have that. That was something that I changed when I got here. So there was old school that some people, you also find some physicians that will say that 2T, but I'll tell you that that's not correct. It's a 3T and an 11T because you can only take 4 away from verbal. It's out of 5. So, and then obviously just make sure, I'm going to tell you, you better pay attention. If you can't calculate that, you're not going to know when to intubate. You need to calculate that. You're going to see a lot of those types of questions. You need to know that. So equal to 8 or less than 8. So very complex pathophysiology with this. Not really, not really. What does it need? It needs the substrates. What are the two things the brain needs to run on? Oxygen and glucose. There we go. Not that hard. So any of that's affected, and we're going to get dysfunction of the brain. Whatever process causes that, you may not be really sure. There's a couple different things there. Encephalopathies, toxins can cause that. Sepsis can cause that. You have bacteria in the blood is going to eat up all the glucose. The glucose is not going to get to the brain. Because that bacteria also needs to survive oxygen. So it's going to take everything the brain needs and suck it up. So hence coma can be any number of causes. So other things we worry about, disorders as far as hemorrhage and result in bilateral cortical dysfunction. So we worry about this. What does that usually present as a hemiparesis or cranial nerve abnormalities, which is why it's so important to do a good physical exam, especially a good neuro exam. You need to get used to that. So usually if it is a unilateral hemispheric disease, i.e. a stroke, small infarction, because that's about 9 times out of 10. The other 1 out of 10 is hemorrhagic. Should not result in a coma if we're just knocking out one portion of the brain. So usually we have to have either the brainstem or both hemispheres affected before we're going to have a significant unresponsiveness that would simulate or be similar to a coma. So herniation syndromes, so we're about that, somebody gets bleeding inside of their head. So that can cause models for unconsciousness, but sometimes we're not sure of the mechanism of that. Sometimes we're not sure. There's swelling in the brain, herniation. There can be from a number of causes. Pseudotumor cerebrae, to name a few. Diabetic ketoacidosis, very common in children, but sometimes it takes a little while to get that figured out. So what happens with this, we decrease, or an increase in the ICP usually causes that. Increase in the ICP. So cerebral blood flow should be between 50 and 100 millimeters of mercury. 50, any time that is out of that range, it's going to be reduced, and we can develop ischemia. And how does that happen? You see that central pressure there. If we increase the ICP, that's going to lower the MAP. It's going to cause that central pressure to go down. It's going to cause that because more ICP is taking away from the MAP. If you want to see exactly how that works for you visual folks, right there. Makes it a little bit easier. The intracranial pressure increases from bleeding, whether that's cerebral edema, which we usually see in either a trauma or a DKA case, potentially a space-occupying lesion, aka a tumor. So all that gets increases, and that increases the ICP, which results in collapsing veins, decreasing the central perfusion pressure, and ultimately reducing blood flow. Reducing blood flow, reducing oxygen delivery, reducing glucose delivery. Make sense? All right. I'm not going to get that crazy in the pathophysiology testing. I'm going to get that crazy. Pay attention to the check on that. So, unresponsive patient, history of seizures. We need to worry about non-convulsive seizures that are ongoing. This person that seizes and continues to be unconscious in a coma, you really need to be worried about this non-convulsive status epilepticus. You need to be worried about that. So it's a good idea if you can figure that out. Oh, they had a seizure, now they're unconscious. They're not moving, they're not twitching anymore, but they can still have this non-convulsive. If that's what's going on, we need to consider that over 30 minutes, and that person needs an EEG. Okay, a person needs an EEG stat, like neurology should be down there ready to do that. We need to see if there's that brainwave activity that's going on. Versus pseudocoma. So all their pupillary responses, extraocular movements, muscle tone, reflexes intact on exam. So if you go to open their eyes, they're going to keep them clenched. If they're truly in a coma, not a pseudocoma, and you go to open their eyes, they should open up freely. But there should be no responses happening with their eyes. So, and especially when you try to look at them, they will avoid looking at you. They're like trying to look away. Like, are you kidding me? So I've actually had an Afghan dude that got blown up, building collapsed, and he came in, faking to be in a coma. So he was doing all this to me, couldn't open his eyelids, I knew he was BSing. So on the spine board, I lifted up his leg. If he had been in a true coma and I released it, it should have smacked back down, but he knew that would hurt, so he just loaded real slow. I got you, bud. You'll be okay. You'll be okay. be expedited. All right, approach these patients. We want to get them stabilized. We want to get our safety net in place. Getting our labs is going to, physical exam is going to really help us out with that. Now, physical exam is going to be a little bit difficult about other than doing your Glasgow coma scale. It's going to be pretty hard to check these people's fairness of real coma. So very liberal use in the CT scanner, provided they're stable. They can be in a coma, they can be stable, they can have stable vitals and all that. But we still want to get them over to get a CT scan. Want to make sure there's not something else going on that we missed. Why? Because people in a coma can't tell you, I hit my head, or I took these drugs, or I've had headaches for 3 years, and I have a brain tumor. They can't tell you that stuff. So you have to have liberal use to try and figure out what's going on. And I'd probably say, if you're not really sure and it was a trauma, go ahead and get that head CT, and let's go ahead and do a neck CT too, to make sure that there's no other trauma. So let's get it knocked out. You get them in the trauma, or in the CT scanner one time, let's just go ahead and knock out a CT and a C-spine CT. So regular C-spine x-rays are garbage. They're worthless. So I know they have you read those, actually worthless, get a CT. But get them up there. How long do you think it takes to get a CT scan of the head? Like 5 minutes, tops. MRIs, half an hour to an hour, just to get an idea of how long these people are going to take up. The CT scans like in and out. All right, obviously we're going to address our ABCs. Consider our reversible causes. So when we're dealing with coma, I'm going to steal the thunder here, but hypoglycemia, and how are we going to check that right off the bat?
Glucose?
Now we get a glucose, and then we worry about opiate overdose. What do we see with opiate overdose? So,
Pupils?
big pupils or small pupils?
Small.
Small, tiny pupils, usually respiratory depression. They're going to be altered. They're probably going to be very sleepy, that type of thing. But you're looking for meiosis versus mydriasis, which is more concerning for the opposite of that. That's amphetamine. Okay. Go ahead. Next time you're drinking at the bar, just look at your bartender's eyes and you're like, man, that's the size of dinner plates. That's how they can rock at the bar all the time. Anyway, AEIOU tips. Great acronym if you're wondering about altered mental status, especially with coma. You should be running through this in your head as far as your differential diagnosis. No, I'm not going to test you on AEIOU tips. We'll get more into that when we get into toxicology, where it gets a little bit more important. But this is a great coma differential diagnosis for you to run through your head real quick. I like acronyms because when you're in a stressful situation, it's a lot easier to start thinking of this type of thing. So, acronyms are great. So, general exam, we want to make sure we're checking for any signs of trauma and any other signs that there's possibilities for unresponsiveness. We talked about these toxidromes. We'll get into toxicology in block 3 a lot more. I'll give you an entire lecture on that as an introduction. When I say introduction, because that technology book that I had is about 155 pages just on overdoses alone. So ER doctors go and do fellowships in toxicology. So just give you an idea of how that realm gets. So right there, I kind of stole the thunder on this, but we have opiate syndrome. So small peoples, we talked about that, but we can have cholinergic. So what is cholinergic? What are people exposed to that we see cholinergic from? Fertilizer, absolutely. Absolutely. Organophosphates. It happens in different places, but what else is kind of like that? Nerve agent. Nerve agent is the same type of response. That's how we treat those types of things. That's why they have lacrimation. It happens in throwing up and stuff coming out of the face, eyes, and having seizures, aka the kicking chicken or whatever they call it. All right. Want to identify the cause of that. Why is things failing at the brain? Why is the brain not getting the substrates that it needs? And then try and initiate therapy. Obviously, ABCs in place, and looking for those readily reversible causes of coma, because we can treat hypoglycemia with an amphetamine 50. We can treat opioid toxicity with Narcan. Okay, Naloxone. So you really want to make a heroin addict upset, give them some Narcan. You just took away their high. They didn't even care if they're about to go into respiratory failure. What you need to do, identify right off the bat, because these are reversible causes. Anybody coming in, altered mental status coma, is dextrose. So I was in ICU. I walk into the ICU one night. I got a 96-year-old gentleman, looks like Santa Claus. He's peeing in the corner of the room. The nurse says, well, I think we need to call a code stroke. I said, hold on, let's get the glucose. Glucose was 26. Amp, I need 50. And he's like, what was I doing? I was like, you just came in the room. But you look like Santa, so it's okay. So, if they're alcohol abuse, we need to consider reaching for thiamine. These are very few times to reach for antidotes when we're talking about altered mental status. But thiamine is something we should be initiated before glucose in an alcoholic because of the malnutrition. Routine flumazenil, what is that for? What is that reversal agent for? Flumazenil? Benzos. It doesn't work very good. It doesn't work. You really just need to kind of back into the benzo. So, and then naloxone, we talked about Narcan. Sorry, I jumped the gun and stole the thunder of that slide. So, if we're worried about increased intracranial pressure, whether that's trauma or something else, there are steps we can do to that. We want to make sure if they are intubated, that we're not having to buck the ventilator. If we need to get more sedative, we need to get more pain relief, because having it chewed down your throat is not comfortable, potentially more paralytic than when you make sure we're increasing that. But ultimately, first thing we're going to do is raise the head of the bed to about 30 degrees. Okay. There's a whole bunch of other things that we can do as far as hyperventilation and potentially giving, high hypersaline types of things. But initially, let's just get that head elevated and keep it midlife. So readily reversible causes, if we can figure that out, and if I give you a case and this patient is hypoglycemic and we get them back with their euglycemic, which is just a term for right in the middle, they're not hyper, they're not hypo, euglycemic, we can get them in that, then we potentially can send them home. If we figure out the reversible cause, we can send them home. Yes, I'm repeating that for a reason. Okay. If we can't, obviously, we're going to admit them, and then if we can figure out exactly potentially what's going on, maybe admitting them to a specialty service, provided that your military treatment facility has that specialty. And if not, then you need to be able to transfer those folks. All right. You need to know those 6 key items. Imperative to calculate the GCS. Okay. Identify altered mental status and question stem and clinical status, and familiarize yourself with AEI details. All right. And for your visual folks, just breaks down delirium, dementia, and a psychiatric disorder. Some people love charts like this. I'm not the biggest fan, but it's out there. The fact that it kind of conceptualize everything. I've yet to see somebody write this whole thing out on a scrap paper, but we'll see.
Challenge accepted.
Questions on altered mental status? Do you guys like the little stories I tell at all, or you want me to keep those to it? Just kind of bring things in like, oh, so
yes.
I squeaked through phase 1. So when I got to phase 2 and I get to like section C things on the job training, if you will, then it helped me out a lot. Keep in mind that it's really cool to see like actual pathology, but just realize that's the person behind that is probably like, oh crap. Not everything's going to kill them, but still some of that stuff can be a very tough pill to swallow. Telling somebody they have diabetes or whatever. It is what it is. Questiones. That's my math on Spanish. No bueno. I'm semi-fluent. I have to be. My wife's family talks crap about the green, but I don't know what's going on. So we know we can pretty much take A, C, B off because none of that was any part of this lecture. I'm not trying to get into your psych stuff, and we should get back down to that stuff. But we got to decide between B and E, and it's been going on for how long?
Hours.
Hours today, so we're clearly in the realm of delirium. And I tell you right now, you better pay attention and look at those. I'm not throwing the same exact question on the test. So what's a CMP is not going to tell you squat, really. I mean, maybe some electrolyte disorders. I told you any anti-epileptic or drug test you send out is going to take 3 days. You can't react on that. Non-contrast head CTE. What are we worried about? This person had a seizure. What do I tell you? Non-convulsive status epilepticus requires a EEG, stat EEG. So they need to know that. So you got to make sure you tease out that like somebody saw a seizure. By the way, a lot of people just think that it's huge seizures. I always ask people if somebody's having repeated seizures, please use your phone and pull it out the next time and see. The thing didn't last 20 minutes. It lasted like 2. Talked about olanzapine, but that's not really our go-to. Lorazepam is kind of the second line. What's our first line? Haldol. And if we're older, we can take a little easy on that. So I would say if you want to get really savvy, get into droperidol. Droperidol is an amazing medication. It took a bad rap. It was being used for a long time, and then they came out with something called ondansetron, and they put all the droperidol back in the pharmacy. It's an amazing medication for pain control or somebody that's having refractive combatants. Oh boy, he's not going to do this. Damn it. Now this is not very nice of me to just space them one point away from each other. So there might be a little bit more spacing on your chest. There's a lot more spacing on the pantry. Not a hard question. Everybody agrees it's E, right? Inappropriate words, 3, and we get 4, and then we end up with 2. So it'll be nice to paint. Okay, 9. Telling you, it's going to be at least 2. At least 2. All right. Press on, you say, okay. That's wonky. So just be aware there's 18 different applications. It's a science of medicine, there's an art of medicine, and not everybody's the same. Same way everybody has different faces, different fingerprints. So those things can present very differently, but we're going to get into headache. I'm going to tell you right now, these first 6 lectures are longer, a little bit more not fun. The last 4 end up actually like pretty fast. Sepsis, a little lecture on bites and stings, which is more of what I would label as environmental emergency medicine. But headaches, broke it up into 4 different chapters. And here is your references. Here's your take-home points. So we want to identify what's a primary versus a secondary headache. Primary versus a secondary headache. So we want them to be primary headaches, not secondary. Secondary means that there's some sort of pathology that's going on. So we're going to roll up giant cell arteritis. Remember, that's older patients, not something you're going to see in somebody under the age of 40. So probably not something you should have on your differential in a 20-year-old, at least not at the top. So sudden onset or during exertion, we need to be worried about intracranial hemorrhage. Low suspicion if somebody is anticoagulated to get a CT scan. So anybody that's anticoagulated that comes in the emergency department, good chance that your fast track, your urgent care is not going to see them, regardless of what they're coming in for if they're anticoagulated. They don't feel comfortable with that. I feel completely comfortable with that. I'm just going to make sure I do my due diligence. So LP, not just looking for infection, but we're also looking for something called xanthochromia. What is that? That's red blood cells in the spinal fluid. Gives us an idea that there's bleeding in the brain. Because sometimes it may be so minute or so early or so late that CT scan is not going to catch it. We'll talk about that. And then we also have our pseudotumor cerebrae, also known, the new hotness is idiopathic intracranial hypertension, but pseudotumor cerebrae is still a term. So we're looking for increased intracranial pressures because of that. Ideally, though, with these folks, you want to get treating their pain first. You're on top of getting their pain under control. So not going to let them suffer while we're doing their workup and start to have the worst headache of their life if you're not doing something about it. We'll talk about how to handle that from an emergency medicine standpoint. But remember, primary, we have no underlying cause. That's what we want to have. We want to have no underlying cause. Versus if we have a secondary headache, there's a cause for that headache. That's something that probably needs to be dealt with. Here's your objectives. And here's your one case. Talked about it as I led into showing this question. So what do we think is going on?
Increased ICP.
Increased intracranial pressure. Probably not a hemorrhage in a 19-year-old. So female, obese. This is pseudotumor cerebrae, idiopathic intracranial hypertension. And we'll talk about that a little bit more. Younger females, usually obese. This can also be exacerbated with things like preeclampsia and eclampsia, but we're going to look for an increased intracranial pressure when we do that LP. 1 times the back. We're going to make sure we check that. Not only is that LP going to be diagnostic, it's going to be therapeutic, because for every cc of cerebrospinal fluid that we allow out, we're going to drop that pressure by 1. So it's usually above 26. Can you check that? We'll talk about this later, so don't feel bad if you can get it right off the bat. So you got to think about worst case scenarios in terms of headaches. Right off the bat, we got meningitis, intracranial hypertension, or high blood pressure. We worry about strokes. We worry about glaucoma because older folks are terrible about communicating. Is it in my eye? Is it in my head? Not really sure. And then we worry about tumors. We do not want to miss these worst case scenarios. So most of the time, very painful, but benign etiology, that's what we want. That's the primary headache. What fits in that category of primary headaches? These are migraine, these are cluster headaches, these are tension headaches. Okay, then we get into secondary headaches, which are associated with an underlying cause. I.e., is this a tumor? Is this a meningitis? Is this a subarachnoid hemorrhage? We get worried about this. Keep in mind, you're going to see a lot of headaches. I strongly treat at least 1 to 2 per shift. At least 1 to 2 per shift. And I don't mind treating that. It's okay. Just make sure I'm not worried about a secondary cause of the headache. If it is, then we need to go investigate it. We need to be doing more. We need to be getting probably labs, CT scans. Probably if we're going to take off that meningitis and that subarachnoid hemorrhage 100%, take it off the plate. Nothing's 100%, but you want to get pretty close to that. You're probably going to have to put a needle in somebody's back. All right, abrupt onset thunderclap headache requires immediate and thorough. So it comes on suddenly. And please, please do not ask somebody, is this the worst headache of your life? Because if they respond with yes, you're obligated to get a CT scan and to do a lumbar puncture. So I don't ask that. Not to say I'm not afraid to do an LP, but I want to do it when it's worthwhile, when I need to. But I'm going to ask, have you had a headache this bad before? If they say, no, I've had headaches this bad, well, then it's not the worst headache. But you're teeing them up the wrong way by saying it's the worst headache of your life. And so, yes, damn it. Document that and then don't do an LP and see how long it lasts. I mean that. So worry about periods of exertion, whether that's weightlifting, people that are vomiting, sneezing, straining, and of course weird, but post-coitus headaches. We do get concerned about that. So that can be concerning for a subarachnoid hemorrhage or a arterial dissection of the carotid, or vertebral basilar circulation, which is at the back, as which is in the back, so don't worry about that. If it's associated with Valsalva, we're worried about mass or tumor. So I will ask them if you sit down, if you go to the bathroom, number 2, and you get a worse headache, that's concerning for Valsalva. Most people don't just regularly do Valsalva, that's for scuba divers. I say if you're scuba diving, every time you go down a little bit, you get a headache, that's not good. I'm worried about a tumor. What also alludes me to tumor is when I ask people, does this headache wake you up, or did you wake up with the headache? It's a very clear distinction. If people say, yeah, I woke up at midnight with a headache, I'm like, oh, that's not good. You're getting imagery. Versus, I woke up in the morning, I had a headache. I'm like, nah, not so concerning. So Valsalva or headache that wakes somebody up at night. Those are red flags. There's a whole bunch of other red flags that there's definitely different acronyms that people use with that to figure that out. So, over than 50, new worsening headache, high risk group, absolutely. What should happen is these people with migraines, cluster and tension headaches, or primary headaches. Primary headaches should decrease with age. Should decrease with age. So all those primary causes. So if those headaches are getting worse and they're getting older, you should be a little bit more concerned. Have your spidey senses, aka Gestalt, should start showing up in the back of your head. You're like, something doesn't sound right. It'll take a little bit, but you'll get there. You'll get there. So we also worry about changes in headache patterns. So if there's a change in that pattern, so they need the same evaluation as they do onset headache disorder. Fever, always concerning. So when we look at those vitals, if they're febrile and have a headache, we really need to have meningitis encephalitis or a brain abscess very high up on our differential. Very high up on our differential. But just be aware, if there's no fever, then there's potential that doesn't mean that there's no CNS infection. That's why you ask people, did you take medications? Taking medications. People came in and they took a whopping gram of Tylenol before they walked in, and the headache's a little bit better. Well, guess what? That took care of the headache. It also took care of the fever. So I always ask parents, very important, especially with pediatrics. And then we always worry about these other ones as well. So if they're anticoagulated or they're antiplatelets. So let's see a bunch of anticoagulants. What's the difference between anticoagulants and antiplatelets? There's really only 2 that I would put in the antiplatelet category. We have aspirin and okay. Hence, somebody's having an MI, you either give them aspirin or they're having a stroke. If they're allergic to aspirin, what do you give them? Clopidogrel. Okay. Plavix. Versus anticoagulants, that's a whole realm of warfarin and all the factor VIII inhibitors. We got a rivaroxaban, or Xareltos, and all that crazy stuff out there now. So, and then antibiotics, we get concerned about that because if they're on antibiotics already, there's potential for breakthrough type of brain abscess or meningitis. So, be concerned about that. Because that is falsely reassuring. Oh, they're on antibiotics, there's no way they could have a meningitis. If that antibiotic doesn't cross the blood-brain barrier, we'll worry about that. So, other things to worry about, yes, we do need to ask about cocaine, methamphetamine, amphetamine group Y. This causes these weird, reversible cerebral vasoconstriction syndromes that can cause in the brain, causing a headache. So, specifically affecting the smooth muscle. So this can also happen. It can happen in the brain. It can happen in the heart too. People sometimes have heart attacks. And then worry about your alcohol abusers as well coming in with headaches. So increased intracranial bleeding. Why? Because those people fall a lot, they fight a lot, and because most of the people have underlying liver dysfunction. If the liver's not functioning properly, it's not producing the coags that you need to help prevent brain bleeds. Also, just global thrombocytopenia. What's that? Increase in thrombocytopenia.
Platelets?
Oh, what is thrombocytopenia? Good. All right. So just be aware that you got to worry about those people as well. So here's the other interesting thing I want you to pay attention to. So known aneurysms, so ask these people about their family history. That's why we ask about family history. If there's any history of aneurysm or sudden death in a first degree relative, 3 to 5 times higher. So ask about that. Ask about that. And then here's the other weird thing. autosomal dominant polycystic polycystic kidney disease. So we need to ask about that because there's a lack of polycystin in the vascular smooth muscle, puts them at higher risk for aneurysms and brain death. So I would definitely know that as far as a risk factor. They past medical history that is very, very pertinent. So keep in mind, migraines can have a positive family history. What do we want to check first? Very important. Meningismus. What is that? Stiffness in the neck, right? So a lot of times I'll have those people say, hey, can you touch your chin to your chest? Doesn't mean that they don't have it. But I want to make sure that we're looking all around, one level above, one level below. Told you about the kid that I didn't look in his ears, but you want to make sure that you're looking in these people's ears, their nose, and throat to identify if there's any other potential contributions or reasons why they're having that headache. So, why do you palpate the scalp? This is exactly why you palpate the scalp. You want to make sure there's no tenderness or temporal arteritis, skin inflammation, infection, but I'm also looking for trauma. Maybe if they're an alcoholic, they don't remember falling and hitting their head, or they don't want to tell you that they fell down and hit their head. Very important to palpate the scalp, looking for any fogginess. So, are you going to see battle signs? How long do you take to see battle signs from a trauma? Anybody have any ideas?
72 hours? 48?
You're looking at usually 24 to 48 hours after a trauma. What are battle signs concerning for what type of skull fracture? It's a skull fracture. Okay, that's usually not going to show up, but I always palpate the scalp because I want to get an idea of what's going on with the patient. And then auscultate the carotid arteries. So if we do meningismus, what are the two tests we can check? So we got a Kernig's and a Brzezinski's. So Kernig's with the legs, Brzezinski's flexion of the neck. So good physical exam. We want to make sure that this is not an eye issue. We want to check the eye. So steamy, dilated pupil is going to give you now more of an idea of a glaucoma, but we look for scleritis, acute angle, glaucoma. Sometimes they're just very poor at explaining that. So if we do that, you want to get very comfortable in your emergency department with checking intraocular pressures. I will tell you now that every ER has a different device. You have some that you have to touch the eye, and by the way, most people, I'll say 9 out of 10, do not want you touching their eyes. You have another one, you push a little button and it like has a little big projector that comes out and touches the eye several times, really weird. But know where that is. You usually have an eye drawer, and it's going to have fluorescein stain and tetracaine and a Woods lamp so you can look for any types of corneal abrasions versus sidel sign. But get comfortable with that device, whatever it is. There's all kinds of Tonopin, all types of different devices. Make sure that those are okay. Anything above 21 is concerning for glaucoma. So checking visual fields, right there, if there's your cloudy cornea, crescent shadow, very concerning for glaucoma. So mental status exam, cranial nerves, we don't get fired up. I still don't know why you guys get super into cranial nerve 1, other than to remember where it is, but really 2 through 12 is sufficient on the patient. Making sure that you're doing good perla. Want to make sure that there's no ptosis or asymmetry with that. Some people can have a physiologic sign, and they should be able to tell you that right off the bat. Motor exam, reflexes, gait, and want to make sure that we're checking those cerebellar functions for those type of lesions. If somebody cannot tandem walk, they cannot walk a tightrope, they should not be able to go home. That's just the way that I see it. And I will fight all day long with neurology to see them in the patient, because if they can't walk a tightrope, then they don't need to go home. They're going to be a fall risk. Checking sensation in the entire body, make sure that you're checking one side and then checking the contralateral side. Limited utility in headaches unless you have some very significant clinical suspicion. So, but if we are going to do some things and they have high risk and we're very concerned, so basic metabolic panel, why we're looking for any electrolyte derangement, CBC, anemia, coag panel, or coagulopathies. ESR, unfortunately, that's usually a send out. A CRP will come back quicker. Worried about giant cell arteritis. also known as temporal arteritis. Blood cultures, if we're really worried about infection, if you're sticking a needle in somebody's back, you absolutely are getting blood cultures here when you see has that spread from the CNS into the actual body. So, and then cerebrospinal fluid, again, we're looking for xanthochromia to rule out that intracranial hemorrhage or subarach or a CNS infection. Again, also that opening pressure to look for tumor cerebri, aka idiopathic intracranial hypertension. Imaging, so it depends on your differential with that. They're a lot younger, you don't have anything to find. So what I'm saying, typical type of measures plus a normal neuro exam, probably not a big deal. We see a change in pattern, consider some imaging. Sometimes I will consider these people that have come in for a lot of headaches because that's what they do. They come to the ER. Most of the time they know what they need. It's a migraine cocktail. We'll talk about that in a little bit. But I will look back and I'm like, man, you've gotten a CT every single time you come to the emergency department. But I want to feel like CTing you again and exposing you to that much more radiology or radiation. No, I'm probably not going to do that. Probably not going to do that. So, but most people, non-contrast head CT, remember, that's like 5 minutes. Now it takes 2 hours to wait to get in there for that whopping 5 minutes, but so be it. So be it. If you're really concerned, potential for MRA. This is not typically something you're going to order from the emergency department, but just be aware if that person tells you, yeah, I've had a history of stenosis, I have a history of congenital abnormalities, I've had a history of dissection, I've had a history of vasculitis, then maybe we get that CT, but we're also going to order this as well. That's usually going to be in conjunction with some type of consultant. And then is concerned for dissection, you can talk to your radiology department. So, but most of this is usually done in conjunction with the admitting team. So there's also something called the MRA. MRI is designed to look for blood vessel diseases, aneurysms, plaques, arterial venous malformations, stenosis, and other types of obstructions. So this is usually, you found something on CT scan, and this is going to be the follow-up that they're going to want. And that's usually going to be recommended by interventional radiology or neurosurgery is going to recommend we need the MRA to guide us in how we're going to fix these repairs. Just to give you an idea of that. Probably not going to ask you a question on that because that's more of an inpatient type of thing. So, and then we're potential for this, LP, lumbar puncture. Diagnostic tool when we're looking for meningitis, subarach, intracranial hypotension, or some meningitis. It's a therapeutic tool as well for pseudotumor cerebri. I told you every time you take a CC out, you're lowering that by a degree on that. Make sure the patient is in lateral decubus when you do that. You can't have them sitting up and you be in lateral decubus so you give us an accurate opening pressure. It's going to give us an idea of that. If we wanted to do that, lumbar puncture right there. So usually L3, L4, L4, L5, L5, S1. A lot easier on a younger person, a lot more difficult on an older person because of stenosis, and a lot more difficult on a person that is a little bit on the heavy side. So a little bit more difficult with that. If you want to, that's a video, you can watch it. It also walks you through it on that embasic.org that I showed you from yesterday. Walk the dog on that as well. So possibility of herniation, of course, associated with this, we want to make sure that we need to rule out several things. So prior to imaging. So no history of immunosuppression. So they have to have normal sensorium, alert and orient times 4, and no focal neurological deficits. So they have to safe to proceed with the LP without prior imaging, provided they meet all those 3 criteria. So all 3 of those criteria. So essentially, if they're not immunocompromised, they're not altered, no nerve defects, you can do the LP without a CT scan before that. If they have any of those things, we need, they come positive, we need to do a CT scan first. Make sure they're not herniating. So abnormal CT has the following reasons why we need to pursue a lumbar puncture, why we need to pursue a lumbar puncture. So there's all those different things. We're looking at they're deteriorating, we're having brainstem signs with focal neurological deficits, a recent seizure, they're not still seizing, because you're not doing an LP if somebody's still seizing, good luck with that. Good luck with that. pre-existing neurological for immunocompromised. So if we can't get that LP, for whatever reason you've tried 3 times, we do not wait for meningitis. That's our biggest concern, meningitis encephalitis, like top of our differential. Their febrile, nuclear rigidity, we absolutely think that this is what's going on. We do not delay that, we get the antibiotics started. So honestly, you can get a pretty successful LP before antibiotics really affect that for about an hour. So about an hour. So, here's your disposition. Most of these folks can go home provided you get their headaches under control. Get their headaches under control. If we don't get their headache under control, they need to be worked up further, then they need to come in. We need to do probably serial labs. We need to get an MRI, MRA. We don't usually keep people in the emergency department for these types of things. They're taking up a bed. They need to be admitted to get those types of things. Keep in mind, people wait months to get MRIs done. And if I'm going to bump somebody from the emergency department in there, I'm taking a slot from them, they're going to be delayed. I'm not going to be too happy. So I've got to be pretty dang sure that I know what's going on. So follow-up plan is very important for our people if we think they have temporal arteritis or idiopathic intracranial hypertension. Those people need to see a specialist. A lot of times that has happened or dealt with a neurologist. And then just be aware of people with chronic headaches. Huge risk for substance abuse because of their headaches. Huge risk for substance abuse. Yes, they do come a lot to the emergency department. You'll figure out, maybe you don't work in your ED enough, but once you work at the AMC, I see patients that pop probably more than, oh man, I want to see that one again. They're high-risk people. They should be identified. Most emergency departments will identify who the right high-risk people are, and that will pop up on them. So, and then again, we talked about, hey, this person's got a CT scan every time they come to the emergency department. Hey, let's not do that again. So, for you visual folks, here's your red flags. Here's your red flags, just an idea of things that, here's things you should probably put in your MDM. Like, they don't have these things, so I'm not worried about working them up anymore, and they can go home. They do have these things, you better have a good reason why they have one of them, where you're doing imaging. We will take a break. Let's see here. We talk about meningitis. Any questions about the boring part about hearing our headaches? So we want to make sure we discuss obviously primary versus secondary. But now we're going to these are obviously the secondary type of headaches, meaning that there is an underlying cause. We wrote about meningitis. So anytime that you have a triad or a pentad, something I would definitely pay a little bit more attention to, or something that you're going to see potentially on the pants. They love to go with these types of things. So that particular triad with meningitis is going to be fever, altered mentation, or altered mental status of neck stiffness. So, but just be aware of, just because that's going on in febrile, doesn't always mean that it's completely bacterial. We can have viral meningitis, we can have fungal or parasitic. Usually don't see a lot of fungal or parasitic in first world countries, but definitely very possible. Where do we see viral meningitis typically?
Kids.
So recruits, you see that, close housing, that type of thing, dorms, colleges, that type of thing. So just be aware of those, especially with those with immunosuppression. We'll be very concerned about those. Say anybody comes in that is immunocompromised or immunosuppressed, so immunocompromised because they have an underlying disease process, immunosuppressed, they have an underlying disease process, but they are typically on a medication that makes them immunosuppressed. Don't worry about those folks. You should be thinking, I'm going to go to the kitchen sink, meaning very wide aperture and casting a very wide net of labs and workup and physical exam. Those are more complicated patients. Be worried about that. Again, if the LP is delayed, we give antibiotics without delay. We need to get those antibiotics. That's the only thing that's going to start working if we're seriously concerned about that. Some people will say, well, the emergency department is so cavalier with that. They intubate people, they give people doses of antibiotics. Well, here's the deal. That one dose is not probably going to do too much damage. If that inpatient team goes, oh, well, guess what? The LP came back normal, it's a viral, and don't give antibiotics. Cool, good for them. So that's why a lot of times we do antivirals with this as well. I let the inpatient team worry about that. But I know that if I don't start the antibiotics early, then this can go very badly. It can go very badly. You'll work with docs and PAs that will do some interesting things in the emergency department and probably go down a rabbit hole. And the reason you're doing that is it probably got burned at one time in your career and missed something. And you're like, I'm not going to miss that again. So you'd be surprised. Sometimes just let them do it. But there you go, immunosuppression, normal sensorium, and no focal neurological deficits. That head CT can again be delayed. Otherwise, if they have HIV/AIDS, cytomegalovirus, any of these types of issues, they are not abnormal sensorium. There are focal neurological deficits. We need to get that CT scan. What are you worried about bug-wise? Yeah, strep pneumoniae is probably your top guy there. Most of the time on the pants, they're not going to ask you second or third, maybe second, but that's usually like an alternate drug. If someone's allergic to something, that's usually the way to go down there. But I would definitely at least know for my pants, if they say bacterial meningitis was the most likely cause, bacterial meningitis, we need to say strep pneumoniae. All the other stuff, not as big, but that influenza is mixed in there, but we should, that should be vaccinated for. Here's your other risk factors. What I want you to pay attention to, we have people that are immunosuppressed, we have alcoholism, because if somebody is a significant alcohol user or an alcoholic, their immune system is going to be down.
The green check mark on the slide before, is there something special that you have on there?
Somebody before me thought it was cool to put a check mark on the slide. No, nothing to do with that. I'll point stuff out to you so if something's underlined and highlighted, yes, we'll probably pay a little bit more attention to that. There's reasons that things are underlined and highlighted or bolded. I don't think I didn't highlight it. But known bacterial infection puts somebody at higher risk, immunosuppression, alcoholism. Diabetes is a huge one, and we see a lot of that in the United States. People that are older, people that have cancer, underlying cancer, and then we worry about our non-vaxxers. So pockets of the country that deal with that. Doesn't matter to me if that's how you feel. It's been proven that they help out, but non-vaccination is why we have outbreaks of measles and all kinds of other stuff. So. All right, how does that present? Again, most common. Number one, headache. That's why we're in the headache portion of the block. So second, fever. And then we have our stiff neck, that's our trifecta. And then, well, the altered mental status, not necessarily the headache. Keep in mind, so I dealt with a lot of this stuff. I got to train in downtown Harborview in Seattle. If anybody knows, that's like number one trauma center there. But also, unfortunately, Seattle has a very high HIV population. So these people come in with that and mention anything febrile, they're definitely getting full Monty, and they're definitely getting a needle put in their back, hands down, to rule out any type of meningitis. So here's how these break down with your demographics. Just pay attention to this. So I talked about that a little bit. Influenza is going to be unvaccinated. Monocytogenes is going to be, if you see that on your pants, that's going to be an alcoholic. Probably not going to get big into penetrating head trauma or post-craniotomy, but that meningitis is very concerning for colleges and people in the military. What do we need to do to diagnose that? We need to stick the needle back. So lumbar puncture, primary method. So we need to be very careful. That's why we ask them if they have any coagulopathy issues. So platelet counts below 20,000. Anybody have any idea when do we look at transfusing somebody with platelets? When do we need to be below? Anybody have a cutoff in their brain? 50,000. So if they're above 50,000, don't give them platelets. INRs, don't worry about that unless they're on warfarin. We've gone a long way from warfarin because it's so affected by people's diets. They're eating green leafy vegetables, it would grow up based on how much vitamin K they have in their body. So we don't mess with that anymore, but just know that that is out there. So we're going to order that gram stain, culture, cell count, glucose, protein. Again, we don't withhold that. It's been on several slides. We don't withhold it. So very interesting thing if you're doing an LP that never gets tubed down to the lab, ever. It gets walked down. That's how important getting that sample is. It gets walked down to the lab. So there's an idea of what you should pay attention to as far as that goes back. What I want you to really pay attention to is just a simple fact that bacteria is going to need glucose to survive. So it's going to eat the glucose. And then when it eats the glucose, it's going to excrete protein. So we're going to have an increase in protein and decrease in glucose. That should go along with your cell count. Then we're going to wait later for the gram stain and to figure it out and then grow it out on a petri dish. And then they're going to put a bunch of different antibiotics on it, figure out which is susceptible, which it's resistant to, and then what is the lowest amount to kill it. You guys remember that, the mean inventory concentration? That's probably the antibiotic that you should go with, the one that requires the least amount of antibiotic. So that's what I want you to get for that. So we're talking about bacterial meningitis here. So complete a CT if you're concerned for your possible herniation. We talked about the risk factors for those. But we want to get that LP as soon as we possibly can. But again, we don't withhold antibiotics. We have about an hour to play with. These are high risk folks. High risk. So obtaining a head CT before. So we have that other 3 criteria that says we don't need the CT. Here's a criteria that says we do need the CT. Here's a criteria that we do need the CT. So obviously papilledema is concerning for what? Increased intracranial pressure. That's a tough thing to see on a ophthalmologic exam, but that's why we teach you guys how to do a optic ultrasound, potential to measure that. Okay, malignancy, then we throw in their HIV and controlled diabetes, older age. So how do we treat this? Right away, ABCs, get all the labs, get the blood cultures. Blood culture is probably going to include from 2 different sites, blood, and then let's go ahead and just be cautious. We're going to get a urine and a urine culture too, just to make sure that we'll roll everything up. Empiric antibiotics, non-contrast head CT, that's what NCHCT is. So LP, and then keep in mind it's going to take a little bit to get those antibiotics up. It's usually, sometimes not necessarily in the Pyxis, meaning it's in a storage unit in the emergency department. A lot of times that's going to be tubed up from pharmacy, or tubed over from pharmacy, based upon where they are in location to the emergency department. So we'll get that started. Sometimes it can take a while, so start that early. Start that early. Here's what we reach for. Again, I don't need you to know doses, but majority general population, 18 to 15 years old, we're going to do ceftriaxone and vancomycin. Keep in mind this is all IV. All IV. Dexamethasone, some people are like, oh, I do it, I don't. I personally give it because I'd rather them have it than not have it. Dexamethasone helps out with any sequelae that might happen. I'd rather, if they don't want to continue that, if they're impatient, I don't care, that's up to them. I'm going to go ahead and give that. And then ampicillin if they're immunocompromised or history of alcoholism, because we're worried about monocytogenes. So, and then if we're concerned penicillin allergy, pay attention to that. So we're going to replace that with Bactrim or meropenem. So again, HSV, if we're concerned about that, if I can't tell definitively from that initial cerebrospinal fluid and I'm worried about viral, I don't care. I'm going to go ahead and give that person a dose of it based like we did. If I don't think that it's 100%. And a lot of times if you do that LP, you have an idea if it's bacterial or not, because if that cerebrospinal fluid comes out and it's got purulence in it, it's got like pus in it, you're like, oh, this is bacterial, I'm not worried about that. Just keep in mind, you can add that. And then recent neurosurgery, cefepime plus bank. Cefepime plus bank. So if you're really concerned, you have any questions, you can always call your pharmacy. They're willing to help out. They are putting a lot of pharmacists inside of emergency departments now to help out with advising. Know where they sit, go and see them. I can't guarantee you that every place is going to have that, probably not. KMC does. So if I have a pharmacy question, somebody needs to be renally dosed, or I will call infectious disease. I called infectious disease a heck of a lot. Because I had people that had like COVID like 3 times. And I'm like, what do I do after the second time? I don't know. Not very helpful. But at least I called them and documented it. So, dexamethasone, that can go in first. They usually have that in the emergency department. That can go in first before the antibiotics. Look at that. I always do this if I'm concerned about meningitis. They can discontinue the inpatient, but either way, reduces hearing loss and any type of neurological sequelae if there was going to be some. So, great slide here. I love this one. Yes, you're going to admit all patients with bacterial meningitis, unless you don't like them. You're going to say some pretty bad stuff. Admit all those patients. They need to come to the hospital. They need to be placed on isolation. They probably need to be in their own room. So when I put like a meningitis patient in a room with a COVID patient, see who wins. Don't do that. All right, questions on bacterial meningitis? Subarach hemorrhage. Another reason potentially for needle in somebody's back. There's a sweet picture. Good picture. 50% 30-day survival rate. This stinks. Subarachs can happen for any number of reasons. Again, remember, worst headache of someone's life, thunderclap. Type mentality comes on suddenly, acute onset. Proven until otherwise. Look at that. 3 out of 4 of those due to a ruptured aneurysm. When I think ruptured aneurysm, what do I think is probably the underlying process with that, aside from they potentially have polycystic kidney disease? What do you think is the real cause of having a ruptured aneurysm?
Trauma?
High blood pressure. High blood pressure, hypertension. Because it's usually interparenchymal versus subarachs. Those end up being more subdurals on the outside of the brain from trauma. So, don't get me wrong, you could have both. That'd be a bad day. But right there, there's the risk factors. Right there, number 1. What did I say? Hypertension. Smoking, drinking a lot. Why do you think people with drinking, why would that cause them to have, not necessarily the trauma piece? Yeah. So people that drink a lot usually have high blood pressure. So why? Because the heart gets pumping to try and filter out all that alcohol. So they're going to have high blood pressure and then withdrawals cause blood pressure go up. And then there's your polycystic kidney disease. Please pay attention to that again. Family history, we have all these other underlying and general types of disorders people are born with, coarctation of the aorta, which usually runs with Marfan's, and then we also with our Ehlers-Danlos and our antitrypsin messes with smooth muscles. So what's our first step before worrying about ruling out subarach? We need to get a head CT. First step, head CT. But keep in mind that head CT is 98% if it's within the first 6 to 12 hours. First 6 to 12 hours. We go past that or before that, there's potential that we need to put a needle in the back. Most of the time it's not going to be before. You won't come in right away, but to worry about that, they come in, they've had a headache for 15 hours, you get the CT, looks fine, and they tell you worst headache of life, you need to put a needle in the back, looking for xanthochromia, that's spinal fluid. And it should look that way. It should have a yellow appearance. It's not coming out as looking all red. Yellow appearance, that's the breakdown of red blood cells. Breakdown of red blood cells. Enzymatic breakdown in blood by bilirubin. So if there's absence of that, so you should be able to see it, but you're still going to get a report and see how many red blood cells. And this should be a lot more than what you consider a traumatic tap. Everybody's familiar with a traumatic tap? Typically, probably the first couple times you tried it, you go in, you're trying to work it, you're working up and down, it's going to cause a lot more bleeding. So, versus if you do a perfect tap, and it's called a champagne tap, no red blood cells, and somebody has to buy you a bottle of champagne. Pretty sweet. One time it happened. One time. Never happened again. Anyway, so we're worried about risk of rebleeding 24 hours. So this person is likely going to be admitted to the ICU for sequential 1-hour neuro checks. It's going to be like the only place in the hospital that they're going to do 1-hour neuro checks. Everybody else is just doing their own thing. But ICU's very big on that, and they have to watch that. They keep their blood pressure down so they don't bleed anymore. What are they going to reach for? What is labetalol? What's the carpine? Calcium channel blocker. So we're going to get that down. We want that systolic, definitely below 160. Dose of labetalol, 100 milligrams, 20 to 40 of nicarpine. We do not want to give nitroprusside or nitroglycerin. That's a contraindication. That will increase cerebral blood volume and increase intracranial pressure. That's not what we want to do. At subarach hemorrhage, you need to pick up the phone, call neurosurgeon again, subrac goes to the ICU for Q1 hour checks and definitely going to be monitoring that blood pressure that entire time. And they're going to have PRN orders for if it goes above. Pick your flavor, doesn't matter what beta lolic, nacarkine, maybe a little bit of each to help out. Questions on subrac hemorrhage? I told you about the subdural with the two meth heads. So this is how that looks. CT, yes, this is typically more from a trauma from the outside. So subdural, epidural, very similar, very similar. So intracranial hemorrhage with or without a history of trauma. So it can be intraparenchymal and then flow to the outside, but it can be with or without trauma. There's your folks that we need to be worried about. So worried about the people that are older, so big falls, chronic alcohol, substance abuse, and those on antiplatelets and anticoagulants. Those are usually your non-trauma patients, typically, except for the elderly, and then patients receiving your antiplatelets. I just differentiated between those. I would get a CT on anybody who's on antiplatelets and or anticoagulants. And yes, that does qualify. A little tiny 81 milligram baby aspirin is still an antiplatelet. I would still be cautious, especially in your elderly people, especially in your elderly folks. So subdural hematoma, we end up having a lot of these. We are concerned about a cerebellar hemorrhage. You need to pay attention to this. So we have a headache, plus we have vestibular systems. Everybody's familiar with the vestibular system, right? On inside the ear. When we start having stuff that's messing with the back of the head, we are having cerebellar hemorrhages. We're going to see vestibular. They're going to be complaining of things like nystagmus. They're going to have ataxia. Complaining of things, disequilibrium, loss of balance, those types of things. So 1 in 10 of all intracerebral hemorrhages. So it usually requires prompt surgical evacuation of the hematoma. So severe disability or death with that guy. Severe disability or death. Versus epidural hematoma, high pressure arterial bleeding, lead to herniation within hours, usually injury related to that epidural hematoma. So we need to recognize that. Usually should catch that pretty quick on a CT. And I'll show you what that looks like in a second. So usually absent because this is not inside the intraparenchymal. This is trauma to the outside of the head. So it's not going to be intraparenchymal. Intraparenchymal leads me to believe it's more of an arterial, more of a high blood pressure type of thing. So if they can evacuate that hematoma, they can take care of that. Usually it's a little bit easier. That's where they start putting burr holes in or doing partial craniotomies to relieve that pressure. Right there, note the epidural. That is a football shaped, considered a football shaped, convex shape, and focal location in this specific trauma. So just think about that flare gun round, just hit that dude right in the front right of his forehead. Right. This is a very interesting one, central venous thrombosis, and I'll tell you a little story with this. This is a little bit more of a zebra, but you need to realize that it's out there. So, younger population. This is a younger population type of issue. So I'll tell you, a young lady came in, a recent viral illness, I think she's about 34 years old, complaining of headache, had nuchal rigidity, was not taking any medication, no fever. So we CT'd her, came back normal, did an LP on her. I let my resident, I was like his first one, so it's probably been there for like 45 minutes, but he's good now. Good, nice, good. Everything came back fine. So I just admitted her for a perceived viral meningitis, gave her some recyclovir. They did a CT scan of her next day, central venous thrombosis. She was clogged all the way from her jugular all the way to her brain. Probably need to see hematologist for like why are you having coagulation problems like that. Total fluke type of thing, that turns into a case for it. But just give you this is a younger person's type of thing, wherever dangerous. But look at your known risk factors. Sorry ladies, but right there, women, and then peripartum period is a hypercoagulable state. But also look at your recent surgical history, and then people that have a history of hypercoagulable states. So these are younger ladies. So usually develop slowly, progressively over days to weeks to a thunderclap headache, to a worse headache of their life. Here we're this younger population, typically a little bit more common in the female population. So sometimes can show up benign, but sometimes can be significant, so a wide array of presentations with this. So we're probably going to order the non-contrast head CT right off the bat. So probably is going to say something's going on, or at least we're going to have some neurological deficits or some altered mental status. But the diagnosis of this, cerebral venous thrombosis, is made with MRV, that's magnetic resonance immunography. You come back and say, hey, I got this young lady, but usually there's going to be some type of sequelae, that abnormal CT that's going to recommend, cannot rule out central venous thrombosis, recommend MRV, or you're going to say this person's still altered, everything's looking good, the LP came back fine, but I'm still having some focal neurological deficits, and hopefully your neurology team will steer you in the right direction. But you need to know if central venous thrombosis is concerning in a young woman who's having altered mental status, focal neurological deficits, a abnormal CT, and not necessarily all three of those, but at least one of those, you need to reach for magnetic resonance immunography. So rare diagnosis again. So rare diagnosis. So elevated LP should give you an idea, like, is this pseudotumor cerebrae, aka idiopathic intracranial hypertension, or is this intravenous thrombosis? So then we need to get that prompt magnetic resonance immunography. If you get flack from your neurology team or from your radiology team, call your neurology team and just say, hey, I want to get this done, and then call them back and say, yeah, neurology wants it. I'm like, oh, I'm sorry, I recognize that. And make it happen. So anyway, LP can be done safely in this. Don't have to worry about that. So here's our other wonky causes. Other wonky causes. Temporal arteritis, aka giant cell arteritis. So affecting small and medium vessels. Keep in mind this is over 50 age. So can increase. Now they can show up a little atypically. They may be like, oh, I feel really fatigued and fevers and I'm having these headaches. Just pay attention, these people can have transient visual loss and then complain of what's called jaw claudication. Now what do you think when you hear jaw claudication? I think this person probably suffers from bruxism, grinding their teeth at night. That's what I think initially. But don't think that in an older person that comes in, probably not bruxism. We need to be worried about this. So ESR elevated, make sure that we check the intraocular pressures, because they're going to be complaining of pain up in this area where the temporal artery is. We want to make sure that that's not a referred pain from the eyes. Okay? ESR, unfortunately, usually is sent out. ESR is fortunately sent out. We'll talk about that. How do we treat it? Just rock with prednisone daily. Now we're going to give it either pulse or you taper it. Usually we're going to pulse it, and every hospital can have criteria for that. Usually it was 5 days till this symptoms abate, but you're also going to pick up the phone and at least call ophthalmology and call rheumatology, provided you have a rheumatologist in your hospital. But give them a call just so they have visibility on the patients. And then maybe drop a consult with the nursing department just to get them in. So most of the time they'll say, hey, just give me their DOD ID, we'll give them a call tomorrow and get them in the clinic next week. So provided we do that. Most of the stuff can go home. We don't usually even know this unless we cannot get their pain under control. But diagnosis, we have to have 3 out of 5 on this table out of 10. 3 out of 5. So right away, you hit the right demographic. They need to be over the age of 50. So, and then it's some new headache, temporal artery abnormality. So that's tenderness to touching that. ESR is probably your send out. So I'm telling you right now, right off the bat, you're kind of going to be down to 4 out of 5 max. And you're probably not going to get that biopsy done in the ED. So as long as you have a new headache, 50 years old, temporal artery abnormality, tenderness, we make the assumption that it's temporal arteritis. We can send out the ESR, probably not going to be back for 24 to 48 hours. You can follow up on that if you want. Any questions? I've never done a biopsy on that, even being in the neurology department, so I don't even know how they would do that. So I should probably Google it or something. Questions on giant cell arteritis, aka temporal arteritis, moving along. Migraine, okay, this is where it gets exciting. Not really. Anybody here suffer from migraines? Not necessarily your hand, you don't have to, but they can be pretty debilitating. I don't suffer from them, but when I see people that have true migraines, I feel terrible for them. So this is just an idea of what types of things they suffer from. So scintillating scotoma. Anybody know what a scotoma is? No. These people actually see spots where it's just black. Usually kind of float around. So it's almost like they're not fully blind. They can still see, but it's just little floaters of blackness that float around. That's what's called a scotoma. So photophobia, obviously, usually phonophobia. A lot of times there's nausea, vomiting. That's really much, these are going to last a little bit longer. This is just a nice little picture for you to get an idea of how this is really done. So, most common in the ED. So, moderate to severe. So, 4 to 72. Most of these people will say that it sticks to one side of their headache, and that is pulsatile, meaning it goes with their heartbeat. So, we have photophobia. So loud noises, bright lights. So please, when you walk in the room and somebody has a headache, don't just like flip the lights on. That's just like, use some other terms for that. It's not cool. It's not cool. So physical activity, these people just want to lay in a dark room and like leave me alone. So yeah, turn out the lights. Now glow. Never mind. That's really good. Episodic or chronic. Nobody got that. We did? Okay. She wasn't playing. Cool. So there's our scotoma again. So with or without aura, not everybody's going to have that aura. So I showed you that video. Again, very atypical presentation of that. Usually start in childhood. As they get older, they peak around 40 and they shouldn't have that issue anymore. At least you hope they don't. Look at the prevalence. So more common in females. 3 times more common. 3 times more common. Females. Just to where that anybody. So aura is described. They usually can tell you if they know their headache's coming on. Similar to people with seizures can have aura as well. Like I know my seizures coming on. Those are people who usually know that most. There's just for you visual folks. So hopefully they try and figure out what the triggers are. But most of these people have similar types of headaches. Prodrome is another terminology for aura. And here's what I want you to pay attention to. In the emergency department, we handle these a lot differently. And there is a headache case out there. I don't know if you guys will see it again for your claim core, but you are in a level 2 trauma center and we expect you to take care of this headache as best you can. So triptans are usually the first time for abortive therapy. That person usually comes in the emergency department, is on a triptan, and it didn't work. So they're like, well, I got nothing else. By the way, most people don't like to take triptans because the gorks are not all day. They're just like zombies. They take a triptan and they're not going to work. Not getting anything done that day. They're just going to lay in a room. Hopefully that headache goes away. So they've usually failed that when they require rescue therapy. What do we do for rescue therapy? I'm going to give them hydration right after that. Because most of the time, if they've been vomiting or whatever, most people with headaches don't like sitting down and drinking lots of water or whatever. So NSAIDs and metoclopramide are the go-to. This is the book answer for titinelli. Now, for me, I will usually throw in a gram of Tylenol in there. If they're PO tolerant, they can take it orally. If they're not PO tolerant and I'm worried about any nausea, vomiting, I'm going to give them a gram of IV Tylenol. Yeah, I know it costs about 20 times more, but I don't care. It's not coming out of my pocket. So, and then we reach for metoclopramide. The only problem with giving this metoclopramide is if we give it Reglan, great medication to getting these people, but we need to combine it with an antihistamine. You want to be mean, you give somebody just metoclopramide with no diphenhydramine. And you want to see if somebody has akathisias, the feeling that they want to come out of their skin. This person just wants to go in the parking lot and run in circles. They feel like they are just going out of their mind, like a serious anxiety panic attack. Do not do that. I make sure, I tell my nurses that I want you to start pushing the Benadryl and then the metoclopramide. Just be aware of the akathisias from the antiemetic. Compazine does the same thing. Do not want to put somebody in akathisias. This is how you get them out of the akathisias. Now you got a benzol. So the other thing is that I don't give anybody these medications. I don't start with that until they tell me that they can get a ride home. Not give somebody a healthy dose of Benadryl, and I always give 50 milligrams. I don't go weeks off with 25. And sometimes I have nurses that question me. But then I explain to them that sleeping people don't have headaches, and then we're cool. And we're cool after that. So, and then there's something called the Think trial, just for you to be aware of. So they were doing intranasal ketamine to try and do that. And it doesn't look that great. Don't mess with that. So your answers are going to be, it says medical mind, make sure we give Benadryl to combat, prevent the akathisia. So sometimes steroids, if that person has recurrent headaches, I can go 10 milligrams of steroid on there. IV dexamethasone, but I realize that you have other things that you could elevate to. So I do the Tylenol, then the Reglan, then I'll come back with the NSAID, then I'll move on to the dexamethasone, and then potentially for caffeine infusion. Especially for your post-LP headaches. So just remember in pregnancy, we have to real carefully treat those. Triptans are contraindicated in pregnancies, they're teratogenic. We can reach for acetaminophen and opioids. I usually stay away from opioids. I'm talking about chronic headaches. I do not want to get somebody an added problem of substance abuse. So, and then ergotamines are absolutely contraindicated. So NSAIDs may be used up until the third trimester Y, prostaglandins, all that other stuff. So, I would usually have that person come in. I start them on these within an hour. With that 50 milligrams of Benadryl, most of the time I go back into the room and I'll hear snoring. And I make sure they get the rest of their IV, and I tell the nurse to call whoever's going to come pick them up. So once I give you Benadryl, all bets are off as far as you're not driving home. And then 50% will have some residual headache. They consider if you at least take them like at least 4 points down on their pain scale that you've been successful. I tell people I'm not necessarily going to take it all the way, but usually I've given you enough medication, you're sleeping enough that you just want to go home. So to increase recurrence, if people tell me they get a recurrence, I'm definitely going to give them dexamethasone. So consider abortive medications. I find a lot of people don't start them on triptans, but a healthy dose of Excedrin migraine that has usually butylamine and a little bit of caffeine in it. Usually does pretty well, much better than just your Tylenol. Follow up with their PCP. Hopefully they can within the first 1 to 3 days. And then give them stricter term precautions. You need to come back to the emergency department, your headache worsens, you get fevers, you get new rigidity, you have any neurological concerns, come back. So, and again, when you're working in the emergency department, I don't care. I'm like, we're open 24 hours a day. Somebody will be here. Somebody will be here. And if I do tell somebody to come back, I might tell my chief, like, hey, so-and-so is going to come back tomorrow. Just give them a heads up. And maybe somebody will snag them from the lady and make them back. They spent like 6 hours a day before. Hopefully that's what we do. All right. Pseudotumor cerebrae, pay attention to, right there, obese women, 20 to 44. So please know your demographics. Know your demographics. So headache, but they can usually have some type of transient visual obscuration. Why? That's intracranial pressure that is pushing on the back of the optic nerves. So sometimes because of that pressure, it radiates down the neck and cause back pain, and then kind of cause a pulsatile tinnitus. So 1 in 3 visual loss. Untreated, yes, can become very serious. Permanent visual loss. What do we see on this diagnostic criteria? Papilledema, and with the otherwise normal neurological exam. Elevated pressures greater than 25. Greater than 25. So, and that is centimeters of water. So, but that CSF is going to come back completely normal. CSF should come back completely normal. So at least 3 of the following neuroimaging findings, which is why we should get a CT, because not everybody's going to have papilledema, and not everybody's going to have a nerve palsy. So, and the sella. So the sella turcica. Anybody have what idea what bone that sits on? Nice. He does crazy. It's awesome. So it's where the pituitary gland sits. So you have distension of that subarachnoid space, and then what's called transverse venous sinus stenosis. You should see this. This should be right at the bottom of the CT scan with findings. They're going to list all this stuff, and then it'll say recommendations or results, findings consistent with idiopathic intracranial hypertension. Or if it's an old school radiologist, he'll call it pseudotumor cerebrae. So LP is necessary. We need to check to make sure that it's spinal fluid. So you purposely remove some of that spinal fluid. So we're going to measure after each removal. So like I said, target pressure 15 to 20. 1 ml results in 1 centimeter of water, 1 for 1. So every time we remove that, based on what that opening pressure is, should be the amount of cc's we need to get back to get that within that target range. I would say I would probably shoot more for 15 than just like, oh, I got to blow 20. Let's shoot for 15, because that stuff's probably going to build up at some point. Acetazolamide, ooh, that's something that we can offer. What is this also used to treat?
Altitude.
Altitude. So HAPE or HACE. Anybody that's done any mountain medicine or climbs a lot, acetazolamide is basically a diuretic. So ultimately with this, we're not worried about lowering them from altitude, we're worried about treating this case of acetazolamide. So again, I don't expect you to know dosages, but I need you to know that this is preservation of that person's vision because we're trying to lower that pressure. So this can be a temporizing thing. So a little bit more treatment is the LP. Cluster headache. There's your diagnosis for these. So these are people that have that usually lacrimation, they're pacing around, they're having a terrible time. So these have circadian type of rhythms. So very small population. And yes, they can be complaining of dental pain with that. This is more of a gentleman disease. So this is a circadian rhythm, meaning it shows up in a certain time of the day, or circa annual pattern, which means it's going to show up certain times of the year. So one-sided stabbing pain. Where do we see this? Lacrimation. These are going to be people that are going to be pacing back and forth. They're not going to stay still. Not going to stay still. What do we give them? Oxygen. What do they give in Europe? It's pretty sweet. They've made derivatives with LSD that don't have the psychoactive component to it. But they'll never legalize that in America because it's a level. Crazy. But you're up. I know. So, but just no oxygen. So, no. Oh, yeah, I guess. Never mind. So, trimtryptan also can be used. For your visual folks, keep in mind, so nasal congestion, lacrimation, they can have some ptosis, so that's lid lag, versus proptosis, which is where the eyeball gets out. Meiosis, so small pupils. Questiones. Here's a sidebar. Ask people about how much caffeine they drink as well. So people can have caffeine withdrawal. And I say caffeine because that can be, and not just necessarily coffee, whatever. So check on learning, and I'll get you moving. Sound good?
Yes, sir.
Run it right up to the, thank you for letting me come in early. I would do that any time. I'm always ready to rock and roll. So here we go. Bam. So it's exertional, that's concerning. It's over the 24-hour mark, so that CT doesn't hold a lot of weight, does it? What do we need to, first of all, what are we mostly concerned about? Worry about subrac. What do we need to do?
LP.
We're going to put a needle in back. You got to rule out that xanthochrome. Past that window of 6 to 12 hours, that CT was a 98% there. Now it's just downhill. So, LP. So we're in the early stages. What does he need first?
CT.
Yep. And then if that comes back, then we look at LP in that guy. Not likely that 23-year-old's going to have an issue with that. It's not a tough one. What I say it needs to be above. Probably needs to be above 25, so there's only one answer. A. Good. Pretty simple, right? There's only one answer there, C or given us. Not super typical, but you know, when you're in the hot seat and the pressure's on, the test is happening. I know. I think it's out the window. It's all good. Just have a safe day, and I will see you